Dear colleagues, welcome to Endo Channel by Gianluca Plotino. This is the introduction of my first lesson on this project. So I want to give you the background of what we are speaking about. The module 1 will be about access cavity and how to access the root canal system with a modern strategy. So this background is something that I like to give you to give you an hint on what we will see during the course. Everything that we do aims to overcome technical limitations in our practice. All the techniques, all the efforts that we do, we try to overcome some problems in the instruments and some limits of the instruments and the technique. When we speak about access cavity, and we speak about the traditional concept of access cavity, as we see in the classic textbook and as we have learned at the university, this classic concept defines an access cavity preparation that aims to visualize all the root canal orifices in a single view, with a predefined outline. So we give a shape that is already predefined in our occlusal surface, without taking care of the root canal anatomy, both for the anterior teeth, superior, inferior, the premolars, but also for the molars. We go to shape a precise shape inside the occlusal surface to access the root canal orifice. This is an old concept. This is the concept that we were taught about during our studies in the past. And this concept was introduced and was related because of the rigidity of the stainless steel instrument that we used in the past for root canal instrumentation. So we have a limitation in these instruments that were very rigid, and given this limitation, we needed to open a bigger access cavity with a predefined shape with an early coronal enlargement to reduce the risk for transportation inside the root canal given the rigidity of this file. So these images are something old. To make a straight line access, removing the coronal interferences, removing the triangle of dentin, to give the rigid stainless steel instrument a straight line access to the apex, was done because of the limit of the instruments, but it was a reduction of tooth structure that reduced the strength of the tooth. So technical evolution is leading to important changes in our clinical approach. The evolution of instruments and techniques has given us a paradigm shift in our therapies. So we don't need to have myths in our dogmas because everything is changing, the paradigms are shifting. And this is something that is happening very fast in access cavity concept. Thanks to the flexibility of the nickel titanium new files, thanks of the properties and the resistance of this file, we can go over a modern molar endodontic access with the principle that David Clark and John Cademy gave us in this article. So very new principle that we can follow. And with my passion of art, I have published a painting on this contemporary atlas of modern art. And with this painting, that seems an access cavity with a not predefined shape, I want to introduce you to this lesson of the course on the Endo channel. Dear colleagues, welcome to the Endo channel. This module will treat about the access cavity and all the strategies how to deal with this step of the root canal treatment. So this project of the Endo channel will be a journey through all the endodontic treatment, and as we know, the main phases of the contemporary root canal treatment are the root canal preparation that include access and shaping, root canal debridement with irrigation with new devices, and the root canal filling of the three-dimensional anatomy through the obturation. When we speak about the first phase, root canal preparation, of course we have the access approach that include access cavity, orifice location and relocation. Then we need to negotiate the root canal, preparing scouting, light path and preflaring. Then there is the real shaping of the root canal with a basic instrumentation. And then the finishing So the refinement and apical preparation, all these steps of the root canal preparation we will see through this journey in this project of the endochannel. But first of all, we have to concentrate about the access to the root canal system, so the access approach. Trend today is the minimal invasive dentistry. Minimally invasive procedure is the trend that endodontists and dentistry in general are following. So if we speak about minimal invasive dentistry, we have also to speak about minimal invasive endodontics. That is a paradigm that is shifting in the last period thanks to the evolution in the techniques, in the technology, in the instruments. I like to speak about anatomically invasive endodontics, not minimally invasive endodontics, because how minimal is the minimal? For me, this is guided by the anatomy, as everything we do. So I like to call it anatomically invasive endodontics. And I will show this concept and my vision on this in the next book that is going to be published in early 2020 by Springer and me, entitled Minimally Invasive Approaches in Endodontic Practice, in which I will describe my vision on the minimally invasive approach, anatomically guided. So how minimal should we be? This is guided by the anatomy and depends by the anatomy and depends case by case. And the golden rule for this is the preservation of as much tooth structure as possible, because prognosis improves proportionally to the amount of sound tooth structure that we are able to maintain, regardless of the type of restoration that is subsequently provided. So our mission starts in preserving tooth structure as much as possible from the access. So we can apply some new concept to the access cavity preparation thanks to the help of the new technologies, new devices that we have in our armamentarium. So when we speak about minimally invasive endodontic and access approach, we are starting from the coronal portion of the tooth. Classic concept in preparation of the access cavity aim to visualize the root canal orifice all in a single view. And we know from the textbooks that a predefined outline of access cavity has been always shaped, given the occlusal surface a precise shape to visualize all the root canal orifices together. The modern access cavity concept that I would like to introduce you is a dynamic concept. It's something that is not related to drawings on a book that aim to teach us how to open an access cavity with a predefined shape depending on the tooth category, but this modern concept is a dynamic approach to the access cavity preparation, given by the anatomy, the coronal anatomy, but mainly the root anatomy and the root canal anatomy. So this dynamic process gives us the rules how to open an access cavity because of the difficulties that we may encounter during root canal preparation by the difficulties of the root canal anatomy. And I want to start from a first case, to underline the importance of this concept. This is an upper molar, a first upper molar with a periodontal disease that must be treated endodontically because of this periodontal disease. So this is an intact crown in which we can shape the access cavity as we want depending on the root canal anatomy. We can appreciate curved roots, especially in the mesial root, and the intact crown. There are not so many cases like this with intact crown that we treat endodontically today, because endodontics today is not needed in, for example, prosthetic treatment to prevent the pulp, because we have minimally invasive prosthetic treatments today with minimally invasive preparation. Then we have adhesive dentistry. So we don't make endodontic treatment for purpose when it is not needed because of caries, trauma, or reason that include the pathology of the pulp. So instead, this case, given the periodontal problem, we had to treat the tooth, and we start from an occlusal surface that is intact, so we can shape our access cavity. And in the shape of our access cavity, we should maintain as much as possible this oblique enamel dentin part of this upper molar that is a very important structure from the resistance of the tooth. So we move this the starting point of the access cavity on the mesial aspect of the upper molars, because the pulp chamber is moved mainly on the mesial aspect of the tooth. So we will see only use very few burrs to open the access cavity with very delicate movement, just trying to maintain as much tooth structure as possible. Maintaining as much tooth structure as possible doesn't mean to be as small as possible on the occlusal surface, but as small as practical. That means we want to have the visibility and the accessibility, some principle that we will see in detail during this course. The access cavity is mesialized because the part of the root, the tooth, that is more difficult in endodontics for the upper molar is the mesiobuccal root with the mesiobuccal second root canal. So we need a better access to that part. While, as we will see, the distal root and the distal root canal will have an access from the mesial part of the tooth. So just to refine the occlusal surface to remove the interferences, to remove the undermined enamel, just to refine the dentin that create interference to our instrument, but do not do a predefined shape of an access cavity. Just open it small at the beginning. Let's have the instrument feedback when you start the instrumentation, when you start the scouting, the glide path. The instruments will give you the feedback for your access cavity, how much big it should be. As soon as we can start, I like to start with mechanical files, mechanical instrumentation. We will see it in the part dedicated, specifically dedicated to this. But I like to start with the mechanical instrument to have a feedback from the mechanical instrument. If it has some resistance to advance, given some interference, we can remove that part of dentin even after we started the instrumentation. Not need to open everything before without knowing the difficulties for an instrument to proceed apically. Look, there are some undercuts that we have to clean, obviously, and we will see how to do. And we can regularize these undercuts, we can remove in a dynamic process during instrumentation, because we feel on the instrument some difficulties to advance. We use some bursts, some ultrasonic tips to regularize the access, to reduce the difficulties for our file to reach the apex in a safe and predictable way. So this is a dynamic process during root canal preparation. Endodontics is a dynamic process, as we will see throughout all this journey in the endo channel. Access cavity is dynamic and is dynamically enlarged if needed during the root canal preparation if the instruments has some difficulties. I don't like to put rubber stop on the access cavity to show how small it is. This is not my aim, but this is to let you know how much we can be conservative, treating all the 4 root canals very easily, in a predictable way, in an efficient way, taking care obviously of the most important part of our work, that is to treat the root canal system three-dimensionally, to remove the infection, to prevent reinfection. And this is the radiograph after this treatment with this conservative approach. But to underline this concept, I have to go back to 2002, when I was graduating in dentistry in the Catholic University of Rome, and this slide is a courtesy of one of my mentors, Enzo Lamorgese. This is one of his case when I was still a student, and we were starting this concept that reducing the amount of dentin removed in the coronal portion of the root canal and the access cavity, not a straight line access given by the stainless steel file that needed a straight line access to reach the apex in a safe way without transportation or reducing the risk given by the rigidity of the stainless steel file, but through the use of modern, flexible nickel titanium rotary files in that moment, we were already able to apply this concept of maintaining two structure because we started to use some instruments that has performance that may help us to follow this concept. So the concept that I'm giving you today, it's nothing new. It's something that we have already started to do in the early 2000s to preserve such kind of amount of coronal dentin that is very important for the resistance of the tooth. And this is thanks to the night-tie flexibility, to the introduction of instruments and techniques and specific instruments that may help us to have this approach. Because not all the night-tie instruments may be used following this approach. This approach depends on the quality of the instrument, on the performance of the instruments, of the material of the instrument, on the quality and the properties, mechanical properties of the file. So not all files can be used with this approach. So we have to choose the correct instrument to follow these approaches. And this approach has been already published in 2007 by me and my group, in which we have analyzed, at that time with rotary files, the possible influence of this conservative approach on the wall thickness after root canal preparation. In a first study, we have studied if we can save coronal dentin by using this approach. And the results of the study were that we can save more dentin if you use this simultaneous approach with the correct files rather than a classic crown down approach with orifice opening and orifice enlargement, preoperative orifice enlargement. We can maintain more tooth structure in this area of dentin. This study was done through cross-section of extracted teeth. In one canal we have prepared with the classic crown down approach, the other canal with this more conservative approach with which we can save coronal dentin above the root canal orifice. So no need to an early coronal enlargement. The second study of this series, in this study we have measured the wall thickness towards the furcation, in the inner side of the root towards the furcation, to understand and to evaluate if the root canal may be straightened by this conservative approach by starting mechanical instrumentation without any early coronal removal of the interferences. These results have been published in one of my books. This is a book that I have written with my associate and partner and friend Nick Grande for the Italian Academy of Endodontics, and that is going published in the early months of 2020. So you can find it. This is an Italian book for the Italian Academy of Endodontics, but the aim is to publish them also in all the other language. In this book, we have presented this result of the residual dentin thickness, and we have measured that the percentage of reduction of dentin thickness towards the furcation is not statistically different using a conservative approach without removal of coronal interferences and a classic crown down approach with the early removal of the coronal interference. So the aim was, given the pre-instrumentation slide and the amount and the direction and the trajectory of the root canal that is always like this, to maintain as much as possible this trajectory even in the coronal third. Do not made a straight line access here. Maintain this because today we have the instruments that may permit us to maintain this triangle of dentin. No need to remove this triangle of dentin to permit an instrument to go inside the root canal straight because of the limits of the instrument. Today we have instruments that permits us to follow this coronal curvature and the apical curvature the same because of their properties. This concept, I call it selective coronal enlargement. This is the dynamic removal of the coronal interferences during root canal preparation with night-tie instruments. So, thanks to the night-tie instruments, thanks to their flexibility, thanks to some specific approach, we can have the possibility to dynamically remove this tooth structure. Only remove the tooth structure that is needed to be removed for the instrument to safely, effectively arrive to the working length. No more and no less. And this is one of the cases that I did in the past in which I followed this approach against, again, a necrotic pulp in a sound tooth structure. This was in 2004. My access cavity opening was traditional but already following some conservative concepts. The outline was not so extended, and the triangle of dentin here, especially on this mesial root of the lower molar, covering the mesial root canal of the lower molar, has been respected and only eliminated through root canal instrumentation, enlarging dynamically with the instruments only what the instrument needs to reach the working length in a safe and predictable way. So if the instrument has some difficulties to reach the working length, we just stop and remove a little bit more the coronal interference, usually with the same file. Do not need to use Largo, Gates burrs, or diamond burrs, or carbide multiblades burrs to remove this interference. Today we have in our hands the possibility to do it together with the root canal instrumentation phase, and we will see this concept along all our journey in the endochannel. And this is the final radiograph at that time, in which I followed this concept to prepare the root canal preparation, try to save as much tooth structure as possible in this area, and we will see why. 2004, graduated, I was growing up, I was giving my PhD in endodontics, and I was starting to go very far in my treatment for the most difficult part of dentistry. In this case, again, pulpitis, we have to treat an almost intact crown, just localize the root canal orifice and have a vision on the root canal orifice with different angulation. We can see the two distal orifices just moving the camera, moving the mirror in one direction, and the mesial orifices in the other direction. So this is something that I already followed at the time. No need to have a visual angulation that permits us to visualize all the orifices from the same angulation, that requires a straight line, divergent axial walls occlusally. We can see the results thanks to mainly to the instruments that we have used, and this is a 14 years control of this case that has been done in 2004. Again, following the concept of minimally invasive endodontics that I push hard. Minimally invasive endodontics for me is anatomically invasive endodontics. Anatomically invasive endodontics is something that I will publish and treat in my next book with Springer, appearing again, even this book in the early 2020, on the minimally invasive approach in endodontic practice. In this book, I will give my vision on the minimal invasive dentistry and minimally invasive endodontics guided by the anatomy. And what guides the anatomy? The anatomy guides us in the so-called conservative endodontic cavity. Check. The acronyms. The conservative endodontic cavities that we have established and defined in this article, one of the first that has been published on this topic, this cavity aims to perform a partial unroofing of the pulp chamber with preservation of the pulp horns, slightly convergent walls, occlusally beveled, to visualize the pulp chamber floor and all the root canal orifice from different visual angulations. This is the definition of the conservative endodontic cavity. The modern cavity that I would like to show you how to perform. And this starts from the concept given by us, by Clark and Academy, in this article of 2010, Modern Molar Endodontic Access. You can see in 2010 this article appeared, and the first article appeared, but as you have seen before, we have started this concept since far longer before. In 2002, when we have the possibility, we developed the instrument to perform this concept. So it's a concept that is clear in mind since the beginning in our work, in our endodontic practice. And we have not to confuse the principles that Clark and Academy gave us of contracted endodontic cavity to the principle that today I always seeing on the social networks of ninja access, because in several articles these ninja accesses that are depicted here, they are classified as contracted endodontic cavity, but it is not like this. There is a big difference, because this is extremization of the contracted endodontic cavities or the conservative endodontic cavities. The extremization known on the social web as ninja endodontic cavity, that aims to perform an ultra-conservative cavity just to locate the orifices with an extreme unroofing of the pulp chamber and preservation of all the pulp horns, extremely convergent walls with preservation of the occlusal enamel, again defined in these articles in which we have investigated the influence of this access cavity design on the fracture strength on the tooth, and we will see the results. This is a three-dimensional reconstruction by my friend Dr. Almira Isufi from Albania of what can be defined a ninja endodontic cavity, with the projection of the root canal orifice on the occlusal surface and just a small hole opened on the occlusal surface through this projection. But this is an extremization of the Clark principles of a conservative access cavity that is very different from this ninja access cavity. And we will have a look deeply in the principles that guide us in shaping a correct conservative access cavity without extremization on one side or on the other side. The principle that Clark Academy have given us in this article has been described in this table. We will mention and we will have a look mainly about the high value to the tooth of the tooth structure, but we will see also the other concepts that are mentioned in this article. This is another case of a periodontally involved tooth with a sound crown that in which we can shape a specific design of access cavity because the crown is intact. That is not so often in our practice. And we have to shape this by saving the enamel, the oblique ridge of the upper molar and the mesial marginal ridge, but we need to have the access to all the root canal anatomy. So we need to visualize the orifices and to prepare. We need the possibility to search and to look for the MB2 root canal in depth under the microscope to see if there is an accessory canal and accessory anatomy. If we maintain the pulp horns like this, we need to clean what is under the pulp horns, the tissues, necrotic tissues, pulp tissues that are under the pulp horns, we have to clean them. So we have to perform this type of access cavity, but we have to keep in mind that we have to adapt our day-by-day practice to solve some particular situations that are involved in this approach. And this is the final radiograph with this classic shape of access cavity that you will see clearly later on, with this maintenance of dentin above and below the orifice, and the maintenance of the soffit in some part of the root of the crown to maintain this archistructure that helps to increase the resistance of the tooth. The Clark Academy gave us a principle of orifice-directed access cavity, not more a straight line access cavity with divergent parallel wall, but just access cavity that is guided by the direction of the orifice. The orifices are directed towards the coronal portion with a specific indication, and this will guide us in our access cavity concept. You can see that if you have this orifice-directed orientation of the access cavity, the orifice projection usually is going towards the enamel on the opposite side. So one of the rules of this concept is that we can remove the undermined enamel, because the undermined enamel is not a structure that has been shown to strengthen so much the tooth. and it's a visual obstruction to the endodontic cooperature. The angle of entry into the canal system are not perpendicular to the occlusal surface, because the access rarely needs to be significantly extended to distal or palatal. We need to extend the access towards the projection of the orifice in the occlusal surface. Like we can see clearly in this image, the orifice projection on the occlusal surface usually came in contact with the interface, with the interference of enamel on the opposite side. So this bevel on the occlusal surface aim to remove this undermined enamel, to reduce this interference from the straight line entrance of an instrument towards the orifice directed direction. So the straight line that we like is the straight line of an instrument towards the orifice directed orientation, not a straight line perpendicular to the occlusal surface of the tooth. Another structure very important to be maintained is the axial wall dentin and part of the soffit. But more important than the soffit itself is the preservation of the axial wall dentin near the soffit. The soffit is a small piece of roof around the entire coronal portion of the pulp chamber. Maintaining the soffit, more than giving us more resistance to the structure itself, may avoid the collateral damage that usually occurs to removal of laterally axial dentinal walls. So maintaining the soffit may prevent us from going to the axial walls to unnecessarily remove these walls. Again, this concept in a clinical case, an occlusal beveled surface, you can see the bevel here, how to remove the enamel, but you can clearly see the two mesiobuccal roots, MB1 and MB2, easily, effectively and clearly treated through this access cavity, this conservative access cavity. These are enlarged and these are filled. And this is the final radiograph of this concept. Maintaining the soffit in this distal aspect, usually is the distal aspect where we can maintain the soffit, can help us to maintain the axial wall without removing tissue, dentinal tissue in the axial wall of the pulp chamber. That is very important. While on the mesial aspect of the teeth, usually it's difficult to maintain the soffit because we need a better entrance to the mesial root canals, but we can maintain this coronal dentin. This coronal dentin below and above the orifice is of very much importance in the fracture resistance of the tooth. And this dentin is called pericervical dentin. The pericervical dentin is the dentin 4 mm above and 4 mm below the root canal orifice, the cemento-enamel junction. And this, the dentin near the alveolar crest. This dentin is irreplaceable. So this dentin is really crucial for the resistance of the tooth, and we must perform all the efforts in our practice to maintain this dentin, to maintain this tooth structure as much as possible. So the concept of beveling the occlusal enamel, removing the undermined enamel, we have seen does not have a great impact on the fracture strength, while and we do it to increase and to have a better visibility to the structure that are below this part of the tooth, that instead is very important to be saved because they increase the resistance of the tooth. And in minimally invasive endodontics, this pericervical dentin is not only saved and maintained by a correct access approach, but also is given by the geometry of the root canal preparation. So the pericervical dentin preservation is part of the dynamic process of the endodontic treatment. It's not only part of the access cavity, but is also part of the instrument that goes inside the root canal orifice. So in a dynamic way, we should maintain the more coronal portion during the access cavity procedure, and then we should maintain the pericervical dentin during the instrumentation procedure. This pericervical dentin is very important for the resistance of the tooth. The arrows show the post-operative post-instrumentation of this upper molar with the maintenance of as much amount of dentin in this area since the beginning. We have the possibility through our instruments to insert the instrument not anymore perpendicular to the occlusal surface, but with an orifice-directed orientation. This will give us the possibility to save dentin in the coronal structure. And the studies that is going on, the international literature, it seems they are going to demonstrate and to confirm the importance of this structure. This study at the field element analysis have confirmed that the stress distribution on the occlusal surface is not very different if we open different type of access cavity, more conservative or more traditional, more expanded. Because, as we have seen, the enamel in the occlusal surface does not increase the strength of the tooth so much. While in this study, we see that the stress on the pericervical dentin increased dramatically with enlargement of the access cavity. So as soon as we enlarge the access cavity and remove the pericervical dentin, the stress increased very much on the pericervical dentin. What does it mean, this result? This result means that the stress is mainly concentrated on this area. That is the area in which, in fact, clinically, we mostly see the fracture of the crowns. When the crown fractures, they fracture in that area, mainly in the area of the pericervical dentin, the cemento-enamel junction, the bone level. We have fracture lines that goes straight there in a knife edge through the cusps, going to and finishing in this area, because this area is more prone to fracture, because it's more delicate, because the stresses are acting more in this area of the tooth. So we need conservative access cavity preparations and conservative root canal preparation to preserve as much as possible this tooth structure when it is needed, when it is possible, obviously. We will see how to adapt our procedure to the needs of the operator. But as in this case, an upper premolar, the first upper premolar, in this case, a premolar with 3 roots, 2 buccal roots and 1 palatal roots. You can see the image of the 2 buccal root canals, the 2 buccal orifice and the palatal orifice. And after the obturation and the restoration, you can appreciate how much coronal preservation has been performed in this case, how much dentin we have maintained in this area. Imagine if you needed to perform a straight line access here to the occlusal surface. You would have removed all this dentin. In a premolar like this, very small, in the mesiodistal diameter, you would have removed too much dentin and you would have reduced so much the tooth structure in that point, making this tooth more prone to fracture. While the aim is to maintain such kind of design of dentin 4 mm above and 4 mm below the orifice to maintain this structure that is very important. Then you can bevel coronally to increase visibility through a more opened access cavity, to increase the light transmission inside the access cavity, to increase the possibility to have a better visibility there. And then you must use instruments made for this purpose, made for these anatomies, that not only can maintain the coronal structure, but also obviously can follow three-dimensionally the root canal anatomy and can have an apical maintenance of the apical curvatures that is very important to the final result. And this is the 3-year control of this case, just then restored with a direct composite, because in just an occlusal cavity we didn't need to cover the cusp if we are able to maintain such kind of tooth structure. In one study that we have performed, we have seen that even if we prepare a lower tapered conservative preparation in the coronal third, we are able to clean the middle and coronal third very effectively. The middle and coronal third, if we reduce the taper of the preparation approaching this, or we use this approach, we can clean very well because we can act there with the irrigants, with the activation of the irrigants, and we can clean very easily. What should be, and this approach demonstrated the possibility to save coronal dentin without impairing the cleanliness. This is in the coronal and middle third. The apical third is a different story in which we have to clean and to follow the anatomy, and we will see in a following appointment in this endochannel. Another study in which the taper of the preparation has been seen have an impact on the fracture strength, especially for higher taper. Obviously, today 0.8 taper is never suggested anymore to be used. There is no so much difference between 0.4 and 0.6 taper for size 25 instruments. So not great difference between these two sizes in the fracture strength, but never go over this taper for root canal preparation. It is no more needed in the modern concept of endodontics. And again, these other articles that we have published with my friend Carla from Lebanon, we have demonstrated if we use a 4 or 6 taper size 30 of preparation, not very different. So the 4 taper is probably more indicated, but not so different with the 6 taper. But in the 4 taper, we have more restorable fracture registered in this study. So the fracture strength is more similar, but when the fracture appear, we have to say that we have more restorable fracture if we reduce the taper, so more coronal fracture. This enhances the possibility for us to then save the tooth after fracture, to restore it after fracture, so to increase the possibility of treatment after fracture of these cases. And another tooth in which it's given clear the idea that when you go over with the sizes of apical preparation over 30, we need to reduce the taper of preparation. 0.6 taper for sizes over 25 is not needed at all, and impair the fracture strength, lower the fracture strength of this teeth. So what's the mission? What's the message? To perform a cavity access and to enter the root canal with this so-called calla lily flower shape. The calla lily has this shape that we are trying to resemble inside the access cavity. Restorative material always should be sacrificed before tooth structure, and we will see better. More occlusal surface tooth structure should be sacrificed for more cervical tooth structure preservation. So this calla lily shape, this occlusal bevel, can be done to protect the dentin down there, because the key pericervical tooth structure should remain as untouched as possible. And this is again another clinical case with more coronal destruction, but with maintenance of these principles, depending on the that does not depend on the coronal tooth structure that we have missed by caries or by trauma, or if we have an intact tooth. In all the cases that we approach, we follow this concept, maintaining as much tooth structure as possible, sound tooth structure. Of course, if we have lost by caries, we cannot replace it, but sound tooth structure we have to maintain as much as possible. As in this case, not only coronally, but given this shape of preparation, we can maintain the pericervical dentin, we can maintain this structure even in a tooth that has been very destroyed by the pathologic situation, by the caries. So this tooth has been very reduced in strength by the caries, so we must save as much tooth structure as possible to not impair more than what the caries have already done the structure of the tooth. And this is the article that was the basis of everything, published in 2017 on the Journal of Endodontics, in which we have demonstrated in vitro what's the best for our access cavity. We have performed a different access cavity, conservative endodontic cavity in green, Ninja ultra conservative endodontic cavity in red, and then a traditional endodontic cavity. And you can see also from the axial shape of these cavities the difference in maintaining tooth structure and maintaining dentin. These are the three-dimensional reconstruction of examples of the tooth structure after the different access cavity, the conservative, the Ninja one, or the traditional, more extended one. And the superimposition of this access cavity gave you the precise impact of how much dentin we can save with the different strategies. Of course, with the Ninja one, we can save more dentin. With the conservative we have in the middle, with the traditional, we obviously remove more dentin in a more classic approach. For a classification of access cavity, just for the studies and for the research that have been done, depending on the volume of removal coronal structure, we classify the Ninja ultraconservative endodontic cavity when we remove only up to 6% of coronal tooth structure. The conservative endodontic cavity is given when we remove up to 15% of the coronal tooth structure. The traditional endodontic cavity is when we remove more than 15% of the coronal tooth structure, measured in these studies submitted for publication. The results of our fracture study says us that teeth with traditional access cavity, bigger axis, larger axis, showed lower fracture strength after restoration than teeth prepared with conservative access cavity or ultra-conservative access cavity. So, today the message is clear: stay conservative, no more to be traditional. To be traditional, to preserve the risk, the tooth from the risk given by old files used in the canals. So be conservative, but how much conservative we should be? In this study, we have demonstrated that ultra-conservative Ninja endodontic cavity access did not increase the fracture strength of teeth if compared with the access cavity prepared with a conservative approach, with a check approach. This happens in all teeth, posterior teeth, premolars, upper and lowers, molar, upper and lower. So in all posterior teeth, we don't need to be ultra-conservative because the fracture strength is not changing. Just stay in the middle, be conservative, and you are able to maintain as much tooth structure as needed for the tooth to be really strong to fracture. So in real clinical condition, a Ninja access has not any biomechanical advantage over a more rational conservative access cavity preparation. This is the message that I want to give you. Be conservative without any extremization, but you have to do a step ahead the traditional access that has classically taught in the textbooks, because the traditional access with divergent parallel walls, removing all interferences, with a straight line access to the orifice for the instruments, reduce the fracture strength of a restored tooth with an occlusal cavity. So we should move towards the conservative direction without extremization. And this is what I do day by day in my clinical practice, in my clinical case. The upper premolar necrosis by trauma, you can start from a very small access like this in the occlusal surface, but never stop there, never finish there. It's not needed to stay so small. You can extend a bit this access cavity from an ultra-conservative to a conservative one without reducing the fracture strength of this tooth. So it's very important, this concept. We all are able, with technology, microscope, devices, to perform an endodontic treatment through this very small access. we are able to do it. It's plenty of cases on Facebook and social network of very skilled clinician, very good to do these cases. We all are able to do it as a skilled clinician and specialist in endodontics, but it's not needed. It's not needed to do this instead of this. We can maintain the same fracture resistance while opening a little bit more this access cavity with a conservative approach that permits us to have a look on the different orifices from the different projections, to have a look on the isthmus and to clean everything, to fill three-dimensionally all these spaces and to perform such kind of endodontic treatment in these difficult canals, very strict, this very curved, with this coronal conservative approach, maintaining the tooth structure, making a coronal restoration following this treatment much easier, increasing the fracture strength of the tooth. So let's move from ninja to conservative. It is not needed to maintain a ninja access. We can start from it, we can study the anatomy, and then we can enlarge a little bit more in an access cavity such this one that permits us to visualize all the root canal orifice, to prepare all the root canal anatomy. We need not to miss any root canal, of course. In this case, the most difficult is the MB2 root canal that we can clearly see through this access, just moving our head, our microscope, our mirror in another direction. We can clearly see the two canals and treat them, even if we don't see the other ones. And we can perform the three-dimensional obturation through these spaces, and we will see the strategies of how to obturate these canals during this journey with our endo channel. So ninja to conservative is my rule. Just instead to start in the middle of the tooth, just in the upper molar, preserve the oblique crest, oblique margin, oblique ridge, enamel ridge, and move your access cavity a little bit more mesial. So just start mesially to the oblique ridge, because the pulp chamber is always mesialized in the upper molars. The important resistance structure here are the oblique ridge and the mesial marginal ridge and the distal marginal ridge, of course. So if you move this axis a little bit towards the mesial part of the coronal occlusal surface, you will be able to visualize the orifice in an orifice-oriented direction without impairing the tooth structure, and moving the occlusal cavity a bit on the mesial part of the occlusal surface of the upper molars, because we don't need to remove this pulp chamber horns, this soffit, over the palatal canal and over the distobuccal canal, because the entrance for the palatal canal here and for the distobuccal canal here, if the orifice directed entrance for our instruments is from a mesial aspect. And you can see, if you shape an access cavity like this, the orifice directed orientation goes under this opening. And the same message is given for the lower molars. The lower molars, instead to open the access cavity in the middle of the tooth, let's move this undercavity a bit more on the mesial aspect. Here we don't have the oblique ridge that is increase the tooth strength, but we need to save the marginal mesial ridge, and to access the mesial root canal, we need to move this axis a little bit more mesially, because the mesial aspect, the mesial root under this pulp horn, we should most of the case remove the soffit because of the difficulties of the root canal. So if we have to remove the soffit here, it's good to move the orifice on the mesial aspect, because the distal canal or canals have an orifice directed entrance towards the mesial aspect of the occlusal surface, and we can save very much denting in the distal aspect and the soffit in the distal aspect to increase the fracture strength of the lower molar. So this is the approach that I follow in molars, that is the more difficult, and you have seen also in the premolars extending a little bit in the buccal and palatal direction. Obviously, up to now, we have mostly seen intact teeth. So situation in which we can shape our access cavity as we prefer. And this intact teeth we have only in primary treatments, we have only in teeth with periodontal problems, as we have seen before, or when we perform prosthetically guided endo. But the prosthetically guided endo is really reduced very much today because of the minimally invasive endodontic procedures, minimally invasive prosthetic procedures that reduce the need for the deep preparation of the external side of the tooth. So endodontically treated teeth in prosthodontic treatment are very much reduced today. Or we have cases of trauma or resorption. So how many intact teeth we find in our practice to be treated? Just my numbers in the last years, just only less than 9% of teeth we needed to make an endodontic treatment because of perio problem, prosthetic reasons, or trauma or resorption. Mainly, we do endodontic treatments in teeth that are have had a loss of tooth structure because of caries or trauma or fracture. And in this classic study of the late 80s, we know that only the endodontic procedures have a small effect on the tooth, reducing the relative stiffness of the cusp by only 5%. So if we only open the access cavity, we only reduce the stiffness of the tooth of 5%. We know it since late 80s. So in intentional endodontics, there is honestly no need to be ultra conservative. Just be conservative as much as it is needed. If we have an occlusal caries that lead to the endodontic treatment, so we have the endodontic procedures and we have a more opened access cavity given by the caries presence in the occlusal surface, we have a 20% we have a 20% loss of strength of the cusp. So this can be the example of an extended access cavity opened with traditional concepts in which we extend very much the occlusal opening of the pulp chamber. In this case, we have a higher amount of loss of resistance of the tooth. But what is more important? The most important structures in the teeth for the resistance are the marginal ridges. So if we lose one marginal ridge, we have a reduction in cuspal stiffness of 46%. If we lose both marginal ridge in a mesio-occlusal distal preparation with an endodontic treatment, we have a loss of cusp stiffness of 63%. So the secret is to try to maintain as much as possible the marginal ridges to increase the tooth structure. But most of the cases that we treat, they are cases with interproximal caries penetrating the pulp, needing the endodontic treatment. So in these cases, we have already the loss of one marginal ridge. What can we do in these cases? We can do a caries-driven endodontic cavity. What does it mean? We must take an advantage from the already lost tooth structure, lost by caries, and perform an access as much as possible through this lost tooth structure while maintaining as much as possible the tooth structure in the sound tooth structure, the sound enamel, and the sound dentin. And with this group of very good friend of mine, Nick Grande is my associate and partner and best friend. He is a teacher of endodontics in the Catholic University of Rome, with Professor Gianluca Gambarini, one of my teachers at Sapienza University, then with Tao Zurek and Mustafa Gundogan from Istanbul and Almira Isufi from Albania. We have conducted some studies to investigate the influence of the conservative caries-driven access cavity on the fracture strength on teeth. On upper premolars, the difference was not statistically significant, but we had more resistance with the caries-driven endodontic cavity. For lower premolars, the same. Again, a little bit more resistance for the caries-driven endodontic cavity. So, what I call strategic access. If we have a mesial caries or an interproximal caries, just remove the carious tissue and try to access the root canal orifice from this direction. So the caries-driven approach is a strategic approach that helps us to go inside the root canal, trying to maintain as much tooth structure as possible on the sound part of the tooth. Obviously, if we leave some undercuts, then we can clean it with ultrasonic tips. We can go in the undercuts and clean the pulp rest and the pulp horns. Those are endodontic ultrasonic tips. They are K files. I suggest these ERI K files because they are very useful. They are already mounted. They have different sizes. You can prevent them. You can use with a specific ultrasonic device with their specific power, so reducing the fracture risk. Preventing them, you can go in the undercuts, as we have seen before, to clean where you can go with the, we cannot go with the burrs. And then we can pass through the restoration of these spaces, as in this case, you can perform only a direct restoration with composites of this distal cavity. So, a restoration-driven approach, if we have an old filling in the interproximal aspect of the tooth, especially if it is mesial, let's remove the filling before, and then if we have to go for the endodontic treatment, just access the canal from this aspect of the crown, while maintaining as much as possible the sound tooth structure. This will increase the resistance of the tooth and permits you to restore then the tooth with a more predictable restoration, even in a direct restoration. Because the larger, as we have already mentioned, the largest loss of cusp stiffness is related by the loss of one marginal ridge or both marginal ridges. So in this case, we have to also come towards the needs of the patient. This was a patient that couldn't afford any difficult restoration. In this upper premolar, the first upper premolar with two old big fillings, decayed, penetrating the pulp chamber, we had to perform the endodontic treatment. I have performed two separate cavities, one mesial and one distal, so that from the mesial aspect, we can have a look on the root canals and can perform the root canal treatment, and then this patient could only afford direct restoration. So in a patient like this, I decided to try to maintain as much tooth structure as possible because I needed to perform the two direct restoration. And this is the final radiograph of the restorations. And this is an image of the final composites. So I imaged that this bridge of tooth in the middle may help us to maintain this tooth more in time. This is the 2 years control, lateral canals filled, so do not accept compromises in the quality of the endodontic treatment, but let's try to maintain as much tooth structure as possible. The 5-year controls and the 5-year radiographs that explain the maintenance of the stability of the situation. When we are in molars, the same concept is applied. Upper molars, the conservative, the caries-driven endodontic access gave us a little bit more resistance, but not statistically different with the traditional. But in this case, what I aim is to maintain as much as possible. As you can see, first upper molar, decayed restoration, mesial access, we can treat with this mesial access the most difficult root, the mesial root and the two mesiobuccal canals, because we have a straight line access there, and then we have a straight line access to the distal canal, because the distal canal, the orifice directed orientation of this distal canal is, you can follow it through the trajectory of this instrument, and we can follow this curvature and treat the double apical curvature with the performant instruments, because we are straight line from here. We don't need to go inside the perpendicularly to the occlusal surface. And this is the clinical image, how we try to preserve the coronal tooth structure, the oblique ridge in the upper molars, treat all the root canals, even if difficult, and maintain as much coronal tooth structure as possible, especially the crucial pericervical dentin. And this is what we have already described very clearly: this mesialized access, the maintenance of the soffit, beveled occlusal enamel to permit the lights to go inside, removal of the restoration, and maintenance of the pericervical dentin in the mesial aspect. Lower molars is more or less the same. Again, our study said that conservative caries-driven endodontic cavity was a little bit more resistant to fracture than the traditional endodontic cavity. In this second lower molar, you can already appreciate the difficult curvatures in the distal root canal and the regular curvature in the mesial one. You can see the old filling, the cariad penetrating the pulp chamber. So the concept is to try to maintain the pericervical dentin, so to access from mesial, to maintain part of the soffit and the axial walls on distal, move through the direction of the files. You can see the distal one has an orifice-directed direction. The mesial one also. The pulp was extirpated, and this was the image that you can see. Just we have removed the coronal fillings and just only small amount of tooth structure. We can go through the two mesial root canals and through the isthmus to clean it. We can go through the distal root canal and the large oval distal root canal to clean it through this access. Don't need to open more. We can easily clean today through this access. And this is the final radiograph. Again, without compromise in the quality of our root canal treatment, maintenance of the curvatures and maintenance of the tooth structure. This is the 3 years control with the only coronal restoration, adhesively cemented. The build-up, you can appreciate the maintenance of the axial walls, the pericervical dentin and the soffit, beveling the enamel and restoring with a partial restoration. And this is what we do day by day clinically. First lower molar. This is the video of this access on this patient. A mesial, really penetrating caries. Obviously, always we must take care about the basis of endodontics. Correct isolation. Rubber dam with the clamp. Since the beginning of the treatment, I like to use rubber dam before to opening the access cavity, with some exception, and use of liquid dam, Teflon, everything is in your hands to improve the isolation of the field. Not only rubber dam means isolation, but all these accessory stuff helps us to isolate. And then with a simple burr, just start removing the carious tissue from the mesial aspect. Remove all the caries, the undermined enamel, in a dynamic way. So just remove the growth of the caries, and as soon as we have removed it, we are penetrating the pulp chamber. You can see. Clean very well the dentin from the carious tissue. Try to be as much clean as possible before to enter the root canals. And just look, we have an orifice directed orientation of the distal canal. So as soon as we are there and we can go inside with a small instrument, we start appreciating the anatomy of the root canal. In this case, I only use a round multi-blades carbide burr just to remove the carious tissue before entering the pulp. I don't like to use round burrs, and we will see. I use them only to remove the caries, not going inside the pulp chamber. And as soon as I have the entrance of the canal, look, this is a pulpitis, it was bleeding. I go inside with an appropriate instrument that we will see farther on in this endochannel, and I try to remove the coronal pulp in the coronal part of the root canal to stop the bleeding in these pulpitis cases. So the dynamic way to open the access cavity means that we already start with the instrument during the access opening, when we still didn't have opened the access cavity. Just to understand the orientation, in this case the main aim was to remove the coronal pulp to stop the bleeding and to have a better visibility in our access cavity approach, and to have a better visibility for our subsequent procedures. So you can see now I use a small burr, like flame burr, to refine the access cavity, to reduce the sharpness of the soffit there that covers the distal canal, and to reduce this sharpness that cover the mesial canal, removing the isthmus and trying to look for a middle mesial canal. And then with the same burr, I perform the occlusal bevel of the enamel, undermined the enamel removed. The round burr at low speed, I only use to finish the removal of the carious tissue. After stopping the bleeding, finish to remove the carious tissue more selectively. I like to remove all the carious tissue and to check it with a probe or with an excavator, a sharp excavator. Now we are almost ready to go inside the root canal after a conservative access opening from a mesial aspect that can be opened more and more through the case. These are the pictures of the occlusal vision. You can see the two mesial canal, the isthmus open, the lines that connect the orifices to the mesial orifice to the distal one, and we will see how to follow these lines and these anatomies in the orifice location part in this channel, how to follow these rules. And this is the distal canal. The distal canal has an orifice oriented direction towards the mesial, so we don't need to remove all this soffit. And this, we can perform all the procedures, the filling procedures through these spaces after the root canal preparation. And look, not compromises in the quality of the treatment. Two mesial canals, two distal canals confluent with this sharp curvature in the apex, not compromise how to perform this. The caries restoration driven access means also that if you have the distal half of the tooth severely decayed, the access can be distalized, not only mesialized. Obviously, if you have a distal caries, it's much more difficult to perform a conservative access than if you have a mesial caries, because the distal, to access from distal, you have difficulty to go inside the mouth. But you can apply the same principle even in a case like this with a double curvature, confluent canal, curvature in the distal canal. I tried to maintain this concept, maintaining the pulp horn in the mesial aspect, maintain the pericervical dent in there, while sacrificing the already lost tooth structure. In this case, obviously, is more difficult because it's difficult to go inside this cavity in a first or second molar, because you have to enter from the mesial aspect. So you need, in this case, instruments, nickel titanium files that are prebendable. So martensitic file with a high performance, so you can prebend and go inside the mesial root canals while preserving most of the mesial aspect. And this is very important. This is the preparation of one of the mesial root canal. This is the preparation of the other mesial root canal. And this is the preparation of the distal root canal. So a distalized access is very difficult. Not always we can be so conservative in maintaining the tooth structure because difficult access to this area. But try to maintain as much mesial tooth structure as possible to increase the strength of this tooth, because this tooth has already lost a lot of tooth structure in the distal aspect. Obviously, with this approach, if we extremize it, we can have some difficulties to perform the root canal filling and the coronal restoration. But we can have some strategies to perform it, This is the first and second lower molar. The second lower molar needed an endodontic treatment. You can see the mesial axis. You can see the strategic shape, larger in the mesial aspect because we have lost a lot of tooth structure by caries. And then going in a triangle towards the distal, because in this case there was only one distal root canal. This guide for the instrument was enough with this shape. We don't need to enlarge more buccal or more lingual, because the instrument will go only in this area to clean and cut the root canal and prepare the root canals. Then we will have to clean all the lateral areas with other strategies. And those are the instruments with the orifice-directed orientation. The mesial one, the distal one, the other mesial one. And this is the radiograph of the working length. Managing of endodontic obturation through this space is possible today, also given by the new endodontic materials that we have, hydraulic cements that are more flowable and easy to penetrate this, and we will see in the obturation part in this channel. And this is the final obturation, the picture after obturation of the distal and mesiobuccal root canal, and the restoration phase, in which we have to take care, obviously, to clean and to fill these undercuts of this area. This is the radiograph. Restoration phases: etching, selective etching enamel, etching on dental, agitating the etching, increase the efficacy of etching, cleaning with the water very effectively without, we have to take care not to include we have to take care to remove very well all the etching inside the pull chamber, and then we perform all the adhesive procedures with all the devices and the appropriate materials that we have. There will be surprises in our endo channel in the future, not only endo, we will speak also about the restoration of endodontically treated teeth. And those are just some images to understand how to perform the restoration in these spaces. Flowable bulk fill composite, well distributed to reduce the possibility to include bubbles. And then after the flowable bulk fill layer, we use compactable material, we use interproximal matrix, all the techniques for the restoration that we all know and we will see in details in the future in the endodontic channel. We restore the marginal ridge, and then with a compactable composite we restore the occlusal surface to the original root canal anatomy, performing the last polymerization under glycerin gel. And this is the final image of the tooth restored, and then there will be the inlay on the first lower molar. This is my direct restoration in this case, and you can see with this approach the limitation to limit the inclusion of voids in the composite layer. We are able to fill all the spaces, even the undercuts, even if we don't see them because of these strategies and its technique. Another opportunistic access, strategic access, can be a buccal access through a buccal endodontic cavity. And in these cases, our study have demonstrated that a buccal endodontic cavity has a higher fracture resistance than a buccal occlusal endodontic cavity. In case of presence of buccal caries, normally, if we penetrate the pulp, we then start the access cavity from the occlusal surface. Now, in some selected cases, not all, not everything treated like this, I'm able to perform the access cavity directly from the buccal surface. Like in this case, a caries in the buccal aspect of the tooth penetrating the pulp chamber. I was able, given the instruments, beveling the enamel, given the properties of the file that I have today, to treat this anatomy, two canals confluent, without compromises. This is important. If you need compromise, you need to enlarge the access cavity to avoid to have compromise. So never accept compromises to the quality of the endodontic treatment just to maintain a little bit more of tooth structure. endodontic treatment first, the quality of endodontic treatment first, and then maintenance of tooth structure. So in this type of access cavity, then we need this restorative approach, bulk flowable composite, in this case not polymerized because I couldn't have any access in this case to the undercuts, so I pushed the flowable composite, not polymerized, so flowable with a compactable composite. So like we do with Guttapercha and cement, this flowable composite acts as a cement in which that will be pushed in all the undercuts to try to reduce the accumulation and inclusion of voids. And this is then the final restoration of the so-called premolar, the buccal one, and then the retreatment and the final crown restoration on the first premolar. So two different opposite approach. One really extremely conservative in the second premolar, the classic crown coverage in the first premolar, because the first premolar was a retreatment, has already was with a post, has already lost a lot of tooth structure. So two different approaches in the same treatment. And those are the controls. This is the 3-year controls with the healing of the lesion on the second premolar. And this is the clinical image of the restoration, direct restoration, and on the crown and the occlusal surface. This is in upper premolars, the same in lower premolars. We can perform a buccal endodontic cavity, like in this case, preserving as much as possible the tooth structure in a tooth that has already lost a good amount of tooth structure. So in this case, strategic access can help us to perform a better treatment for our patients. I have introduced already the concept of removing the restorative material first. This is very important. So a larger outline form through the restorative material should be cut, because the restorative material are replaced. What is not replaceable is the tooth structure. So restorative material we have to remove, because we can redo it. Then the access should be vision based when we remove the dentin, but remove before the filling material on the occlusal surface, so you can have a better visibility there. You can have more light going inside these root canals. This will help you to increase the visibility while maintaining a very small access cavity. So when we are indenting, just remove the smaller amount of dentins possible. And this is the radiographic example. A very big coronal filling, we remove the coronal filling, and then we will maintain less, we will be less aggressive on dentin, because the dentin is irreplaceable. The coronal restoration, we can do it again at the end of the treatment. We treat both mesial root canals, the curved distal root canal, the palatal, while opening the material, while maintaining the tooth structure down the material. Always the same. Remove the material, don't need to maintain it. You can bevel as much as you want to have a better visibility down there. Maintain, look, the pericervical dentin here, that is crucial for the fracture strength of the tooth. The same for the crowns. I'm not used to perform the treatment through a crown, especially in retreatments. Like in this case, if I have to pass through a crown in the treatment and I see something like this, I remove always the crown. But if I have to pass through the crown, I can open to see what I'm doing. I can clearly see that the fiber post, and to remove the fiber post, I must clearly see everything through the crown. Obviously, this is an old crown, very bad. We will replace it, so this has been done only because they need to pass through the crown because of the treatment. This is a new zirconia crown. In this case, the access was more conservative in this lower molar. More conservative, trying to maintain a little bit more the crown, even if the crown is replaceable, but is replaceable with another material, with a composite material, a composite restoration. So trying to reduce the amount of dentin removed and the amount of crown removed in these crowns that we have to maintain. And for performing this, I like to use specific burrs to open the crowns. These burrs from Diatec, they are coarse multi-rayed diamond cylinder round-handed burr. This is a crown and bridge separation kit in which we find different burrs, 3 burrs with the cross-cut design, 1 tungsten carbide burr and 1 coarse multi-layer diamond cylinder round-hand burr to penetrate the crown, as we will see now. This kit helps you to perform your treatment through the crown in a safe way. Always, I like to underline, isolation is always the starting point. Rubber dam and a liquid dam to isolate perfectly the space. Then, always use new burrs to perform this access. And with control your high-speed handpiece, it should not have high vibration, because especially when you have ceramic on metal, like in this case, or ceramic on zirconium, ceramic tends to detach to the metal or the zirconium when you cut it. So you have to reduce the vibration and you have to use new burrs in these cases to reduce the damage on the ceramic. I like to use the diamond-coated burr from this kit to remove the ceramic if we have ceramic on the metal or on the zirconium. So very effective burr, very effective in cutting, long-lasting, permits us to remove the ceramic with low vibration. And then the multi-blades, carbide burrs or cross-cut burrs to remove very effectively and fast the metal part or the zirconium part. This is very fast. Look, it is very effective in removing this part of the metal. Obviously, always use new burrs. And then I took again the diamond-coated burr to open the access cavity. In this case, it was a vital tooth under a bridge that got pulpitis, so we need to perform the neurontic treatment through the bridge. That is something that I'm not used to perform so much. But in this case, the bridge was very good, very well done, and the canal was easy, and we performed this, trying to do it in the most conservative way. Beveling the ceramic, trying to reduce the possibility for the ceramic to be chipped, because the problem here that we are creating a discontinuity in the material, in the crown. So we increase the possibility of a chipping in the ceramic. We have to say the patient that there is possibility that the ceramic will chip in the future. This is the working length radiograph, the instrument inside, the final radiograph after the root canal filling, and the 1-year follow-up. So this is what I think it's good to do passing through a crown, even if I don't do it very much. Just in primary treatments, when it is needed because the crown is well done. Use this technique and just increase the visibility of the light, beveling the occlusal surface, because especially metal crowns, in metal crowns it's very difficult to have a good visibility down there for finding the orifices. What about anteriors? We have only spoken about posteriors until now. What about anteriors? Anteriors we have spoken less because honestly a conservative approach is less important in anteriors. Why? Because since the first study published on the literature, this in 2014, these authors have demonstrated that the mean loaded fracture for a conservative access was not significantly higher than for a traditional access in anterior teeth. In anterior teeth, there is the tendency of more untouched surfaces inside the root canal with a small access with no statistical differences in anteriors. So, in the anteriors, we have not a very big advantage opening a very small access cavity in terms of fracture strength of the tooth, while we can increase the difficulties to remove the contents, the pulp contents, the intracanal contents, because of the small smaller access. And this may lead, for example, on what has been established in these studies that have investigated the effect of access design on intracondylar breaching of endodontically treated teeth. So, in this case of a very small ninja access, it's more difficult to remove all the pulp tissues, all the tissues from inside. So, it's more prone, these teeth are more prone to be discolored in the future. And also, performing the bleaching in these discolored teeth is more difficult and less effective rather than doing it in this kind of access cavity. So, in these cases, the use of a conservative access design for bleaching discolored maxillary central incisors affected the acceptability when compared to traditional access. And the traditional access honestly have not so many disadvantages in anterior teeth. Furthermore, but we have to develop the concept of traditional access even in anterior teeth, because the research is teaching us that it's important, some particular structures of the anterior teeth are very important. For example, the palatal aspect of anterior teeth is very important in increasing the fracture strength of the root. So if we have the palatal aspect of the anterior tooth, the tooth will be stronger than if we only have the labial or the proximal aspect. So the palatal aspect of the crown of the teeth is very important for the strength of the tooth. For this reason, we have changed the way how to open the anterior teeth. Classic openings was like this: going inside the cingulum, perpendicular to the palatal surface of the anterior tooth, and then going inside the pulp chamber, and then going more parallel to the axial axis of the tooth to increase and remove the interference coronally. So this was the traditional access. Now we clearly know, since many years, that the anterior teeth, the pulp, have this shape. So the orifice directed in this case, the orifice direction in this case of the only one canal is perpendicular to the long axis of the tooth. So our access cavity today, if we want to follow modern concept, should be more parallel to the long axis of the tooth. We don't want to go inside the palatal aspect of the tooth with the burr, because it's not needed, because our instruments should go inside the tooth with a straight line access with an orifice directed orientation. And moreover, without removing this part of the tooth, we can maintain all this palatal part of the crown that we have seen in the study that we have seen before. It's very important for the maintenance of the strength of the tooth. And this is a clinical case, a clinical example. Central incisor, we need to treat it because of necrosis after coronal filling. Again, perfect isolation of the tooth. Look, the inclination of the burr. The inclination of the diamond-coated burr to open the enamel is parallel to the long axis of the tooth, palatal to the incisal edge. So first rule for me, especially in the upper incisor, never touch the incisal edge. Stay palatal to the incisal edge. This is for aesthetic reason. Just go vertical, parallel to the long axis of the tooth, palatally to the incisal edge, while maintaining all the cingulum, that is the more resistant part of the tooth. So we will see which burrs I like to use in all these cases, but mainly I use only one burr for this case. Just one burr to penetrate the pulp chamber, like this, in an orifice directed orientation, directed through the palatal portion of the incisal edge that permits us to go inside the canal with this direction. And the instrument, this is the access cavity. This is not a ninja access cavity. This is a conservative cavity because it's not traditional, because we moved this conservative cavity more incisally. So we don't need anymore to perform a triangular cavity to include the pulp horns, because we can include the pulp horns going from mesial from one side and from distal from the other side of this cavity. And the instrument will penetrate, will go inside the canal with a straight line direction. It is straight inside the root canal without any interference. And this is the final result of this tooth. Just maintaining as much tooth structure as possible, but the tooth structure that is more important for the tooth to increase the strength. That is the palatal tooth structure. And again, other examples of anteriors with the same style of accesses. Just, you can see, you can touch a little bit the marginal incisal edge if you need, without going buccally from an aesthetic point of view. And perform your treatment through these spaces. You can clean, fill, and save these teeth. Obviously, with the anteriors, we have seen we have not great impact on the fracture strength of this. It's more related to the maintenance of the palatal cingulum. So we can also enlarge a little bit more while maintaining the palatal cingulum. So the strategy for the inferior teeth will be more and more related to the strategy of the operator, to the operator needs. And we will see a couple of different examples. This is an extremization following the needs of the operator, a mesio-buccal caries of this lower incisor. Accessed through this mesio-buccal access, we have here also the difficulties of the canine, the malposition of the canine that covers, but we can perform this access because we have the instruments that permits us to do this. But not only, we will see how much it is important, the CBCT, for example, in these cases, how much it is important to have a look on the canal that is only one canal, not two canals. We have to study it on the preoperative CBCT, because if the preoperative CBCT says us that we have just one canal, we can perform this access in which we have not a great visibility without impeding the cleaning of this canal. If we see on the CBCT that we have two canals, if we have doubts clinically, we have to do the CBCT. If we have doubts clinically and we don't want to do CBCT, we have to open a bigger access cavity. So the choice of the clinician, the strategy of the clinician should be decided. If we want to perform a smaller access cavity, we sometimes need to perform the CBCT to confirm we have only one canal in this case, or we have not accessory canals. If we don't want to perform the CBCT, we need to open an access cavity that permits us to have a better visibility to all the internal anatomy, to have a look under the microscope if we have the second canal of this lower incisor. In this case, it was only one canal. The CBCT said us. So we finished the treatment through this access and then we performed the conservative restoration. This is an old patient with not great requests. So she wanted just to finish as soon as possible in the most conservative way, most cost-effective treatment. And this was, in this case, the most cost-effective treatment. The next case will be completely different, will be the opposite. Another case in which we must follow the needs of the operator. The needs of the operator in this case are to solve this internal root resorption. As you can see by the CBCT, clearly you can see the internal root resorption here. And we have to manage it. We have to manage it through an access cavity. How big should be this access cavity? We don't know. We don't know. We need to plan it through the access cavity that we can perform. Look how much it is, how big it is the internal resorption. And everything is calcified coronally to this internal resorption. You can clearly see from these views, everything is calcified coronally. So it's not easy to find this way, and especially it's not easy to find the canal down the resorption, because the canal down the resorption is very small there. And so this is the clinical video of this case. As soon as we have accessed the root canal and we have cleaned the internal resorption, the difficulty in this case was to find the very small dot where the canal was under there, because there was a very big space created by the internal resorption. So with the ultrasonic tips, we needed to go there to find this small entrance of the root canal that was very, very small, and we didn't know in which direction it was. So it was not easy. This was the most difficult part, not to clean the internal resorption, but to find the small orifice down the internal resorption. As soon as we found the orifice, we start immediately for the preparation of the root canals with mechanical files, as we will see in other parts on this channel, and we finish the preparation, but you can see which big amount of tooth loss we had given by the internal root resorption. So this access cavity in this case was completely different, because the need in this case was to find that small dot of the canal, and the access cavity was really destructive in this case, but not so much destructive more than the internal resorption was. If you see the outline of the internal resorption before and after and on the restoration, you can see the internal resorption had only was the only thing that we have removed, and coronary to the internal resorption, we had the need to remove that structure to clean the internal resorption and to find the canal apically. And these are the controls at 6 months and 1 year. Of course, I put a post in these cases to try to strengthen the tooth structure and the walls of these tooth that are very small and thin. And we have to give an advice to the patient that this may be a problem for a fracture resistance of the tooth that is, in any case, arrived at 2 years, at the 2 years control. So what's important for concluding this space on the access cavity, for me, is to establish the so-called VA principles. We have called VA principles the principles of visibility. We need visibility of the floor of the pulse chamber, and A as accessibility. We need accessibility to the roof and to the floor. The visibility aims to visualize the pulse chamber floor and all the root canal orifices, even if in different projection. As you can see by these images, you cannot see all the root canal orifice from this occlusal cavity, but you have to move your head, your mirror, your microscope to see the different root canal orifices of the 4 root canals. But this means that we have an access cavity big enough that permits us to have visibility to all the floor of the pulse chamber, to have a look for accessory anatomy, for accessory canal, and don't miss any canal. This is important. Our access cavity may give us the visibility to do not miss any accessory anatomy. And then, once found this accessory anatomy, we need to have accessibility to this structure. So we need accessibility and possible access to all the floor anatomy, to all recesses, even that are not visible by only one perspective. For example, in this three-dimensional reconstruction of this upper molar, the distal root, the distal part of the tooth has the distal buccal root canal and has this accessory anatomy that can be accessed from the palatal side, and then it's like an accessory canals merging to the distal buccal canal there. So we need the visibility to this area, and we need the accessibility to this area to clean, to shape, and to debride these areas, to reduce the possible infection, to remove the tissues from there. So this is very important. Then we can navigate inside the root canal with our instrumentation procedures, but it's important to remove these areas and to have accessibility of these areas. Then accessibility not only on the floor of the pulse chamber to treat these areas, these lateral areas, this anatomy, but also accessibility to the roof to the anatomy of the roof, because if we have underlined that we can leave part of the roof, the soffit of the pool chamber, then nothing there there is not everything visible. We need to access that area. For example, the maintenance of a pulp horn, maintaining the part of the soffit, is very important to following these principles. So this principle must be followed with an armamentarium that we need. And I don't like to use so many things. I don't like to use so many burrs. I just like to use few burrs, a couple of burrs for all my axes. And we found these burrs in the dental catalog of Diatec rotary instruments by Coltin. I always use a round-handed tapered diamond-coated burr and a flame burr. And I will see how to use them. The first burr is the coarse multi-layer diamond cylinder round-hand burr. This is the code of this burr, usually in size 12, 14. 14 it's a little bit bigger. 12, with 12 you can do everything, even in smaller anatomies like incisors or smaller crowns. We use this diamond-coated burr to penetrate the pool chamber. I like this tapered burr because it reduces the possibility to overextend, to over-enlarge the access cavity with divergent axial wall. And moving this burr, this is the first step, the initial step of opening the access cavity. With all the concept that we have already underlined, preserving as much as possible the soffit, the pericervical dentin, but accessing the root canals. Then I like to use this 65 and 45 micron diamond burrs, multi-layer, made for low speed handpieces to refine the pool chamber. So with the diamond-coated tapered burr, I do everything. And to refine the pool chamber, I use these flame burrs to refine, as we have seen in the video before, to smooth the possible interference of the soffit and to smooth the possible interference in the coronal aspect. So like a football burr, slimmer, so we can go see both deeply inside the pool chamber and in the coronal portion to create this enamel bevel, to remove this undermined enamel, to perform the technique that you have clearly seen during all this lesson in the endodontic channel. The slightly tapered round end burr is gross grain, usually the blue grain, size 12 and 14 available. The largest diameter is in the working part, so usually the tip is even smaller, so it's very good also for smaller anatomies. I don't like round, flat end burrs because the round end creates smoother cavities. Our habit is to use round burrs to open the access cavity. I don't like to use round burrs, but this round ended of this burr is like a ball that helps us to create the same effect like a ball burr does. But the ball burrs I don't like because they are effective, but it's difficult to create a directional control on these burrs. I don't want to remove the soffit like this. I don't want to go in this direction like this. I don't want to risk perforation. I don't want to remove the undercuts. And with these burrs, round burr, doing like this, it's possible to create such large access cavity there in the axial walls of dentin and there where it is important to maintain the pericervical dentin. So when do I use a multi-blade carbide stainless steel burr with long neck, size 12 and 14, just for the pulp removal and for caries removal in the coronal portion, as you have seen in the video before. I never use it to go to the pool chamber floor or to go to search for the root canal. If we need a round burr to search for the root canal, I like some specific endodontic kits with very small round burrs, very long round burrs, specifically designed for going to reach the root canal orifices, and we will see in the next appointment about the root canal orifice which are the strategies. Or the strategies in my cases is to use ultrasonic tips to the root canal orifice. We will see very clearly in the next appointment in the endo channel. But speaking about ultrasonic tips for the dedicated to cavity access, I like this kit, the Cavi Tips by VDW with this ultrasonic device, because this ultrasonic device you can perfectly fit with the specific power for the specific tips. Look, Cavi has the specific power in blue, but I like to use these ultrasonic tips only in the pool chamber floor, limiting their use on dentin just to look for root canals, so they will be object of the next step, orifice location, not for refining the access cavity. So I use them with this purpose, going on the floor, looking for the root canals, troughing through the root canal to the calcification to find the root canal orifice. I don't like to use this type of ultrasonic tips to refine the access cavity on the axial walls. There is the tendency, and a lot of people teach to use ultrasonic tips to refine the access cavity. For me, this is not a good concept, because we don't need any refinement of the access cavity. We don't need any straight line access. We don't need any divergent walls, given the concept that I gave you today in this lesson from the endo channel. So don't use ultrasonic tips for this, and I don't like to use also non-cutting tips to remove the interferences, because we have seen we don't need to remove the interferences. So this is an old concept. I don't like these burrs because we don't need these burrs today. The non-cutting tip, they are needed only to remove the interferences and to open an access cavity like this with a traditional concept, that this is no more what I would like to show you. Don't use ultrasonics to refine the access cavity, also because in these articles that we are submitting for publication with Carla Zeugeb from Beirut, my great friend, we have seen that if you refine the access cavity with the ultrasonic tips, we have seen more specimens with micro cracks in the coronal tooth structure. So it seems by these studies that opening the access cavity with the burrs and then refining it with ultrasonics may create more cracks because of the effect on the ultrasonics, especially on enamel. Those are the different sections in which we can appreciate the micro cracks. And so I would not suggest this to refine the access cavity, especially to touch the enamel, because the vibration of the ultrasonics may create the microcracks, and in this case, we don't need to do it. We don't need to do it. We just need diamond-coated rotary burrs to perform the access cavity, and another burr to perform the refining of the access cavity. The Gates Glidden also may be something that is inside our armamentarium, not for going inside the root canal, so not for doing the purpose that they have been created for. The purpose for the Gates Glidden was to create the pre-flaring of the root canals, pre-enlargement of the root canals. No, those are like a plain burrs with a very long neck and delicate neck, very soft, that we can use in the pool chamber with lateral brushing movement to refine the pool chamber floor, to refine the orifice, only up to the orifice. But this is something simple that we can use only in size 2, 3, maximum 4. So the dynamic access concept that I want to bring you with this lesson, that with an active feedback given by your instrument, means that we need to start with a conservative access. Check for the visibility, for the accessibility. If we don't have it, start again with a bigger access cavity until we don't find it, the accessibility to the floor, to the roof, and we cannot start with the next step of endodontic treatment, to find our center, to follow our aim, to follow our concept, and to follow our principle, and to reach our objective. In this case, the terms extension for prevention, that I don't like linked with the conservative restorative dentistry, may be used for endodontics with the terms that extension for prevention of any anatomy. So we need to extend a conservative access cavity only if we have some difficulties. Only if we have some difficulties to find and to locate the orifice, to prepare it and to instrument the canals. In this dynamic process, we can go back in this process, starting to enlarge a little bit more the access cavity strategically only where it is needed. So extension for prevention when and where it is needed. And those concepts have been clearly defined by Charlie Boveda and Daniel Kishen in this article on endodontic topics, and will be described in the first chapter of my next book that will be published in 2020 about minimally invasive procedure. In this article and in the book, we will describe the special equipments that are very important for the endodontist to perform a very specialistic treatment. These equipments are very important for the access cavity design, but probably are more important in the next step. So the special equipments, we need microscope and loops. I like to say that I always start with my loops for 4 to 5 to 6 per magnification, and then I use the microscope when it is needed. Then we use ultrasonic device and ultrasonic tips. We have seen in this lesson how to use them. And we take an advantage from a three-dimensional diagnostic tool like the CBCT that can guide us in our treatments. But the most important special equipment is our time and our passion on the work that we are doing. And with this particular painting that I have created, I want you to give my appointment to the next step with this endo channel, the orifice location, in which this particular special equipment will be much more important to solve the more complex situation.